Thank you for joining us today. My name is Janic, and I'm the Health Information Specialist at Brain Tumor Foundation of Canada. Today marks our 5th of 12 webinars that we are hosting this year, and today we have Sally Boyle joining us for the presentation. Sally is the program lead for the Southwest Self-Management Program. She is a certified diabetes nurse educator and has over 20 years experience and strong knowledge of healthcare delivery and chronic disease management. She's passionate about clear communication and its importance to bridging knowledge and behavior. Today's Sally's presentation is entitled Health Literacy and Brain Tumors, and I welcome you, Sally, and I'll hand it over to you.
Okay, thank you, Janic. Good afternoon, everyone. Thanks for joining us. So today I'm going to talk to you about health literacy and what it means in our environment and health care. So we're going to go through some slides, and as Janic said, any questions, please send them through, and then we'll hopefully get to them all at the end of the presentation. Just trying to advance the slides.
You just click your mouse there, Sally, sometimes on the slide, and then you should be able to advance it with your arrow.
Oh, there we go.
There
okay, thank you.
No
stalled there for a minute. So the first slide is just to go over sort of the learning objectives for the webinar. We're going to talk about what health literacy is. We're going to look at the prevalence of and the effects of low health literacy, especially in Canada. Understand the role of us as healthcare providers and even as family and friends in communicating clearly, and also apply universal precautions in health communication. Just a quick caveat that some of this study, some of the information I'll share with you is American, and the reason for that is because the U.S. is about 15 years ahead of us on this topic. They actually have legislation in place around health literacy in plain language. So it's not that I am American, I am Canadian, it's just that a lot of the studies have been done in the States. There are some in Canada that I will reference as well. So this one definition, and there's many out there, although they're very similar, is a Canadian definition of health literacy. And health literacy is the ability to access, understand, evaluate, and communicate information in a way that we can promote, maintain, and improve health in a variety of settings across our life course. So health literacy is very important whether you're a young child up until an older adult across that continuum of care. But it isn't just about our patients or our clients. It also includes the ability of us as health professionals, as institutions or organizations, to be able to communicate effectively so that the people that we serve can make informed decisions and take appropriate actions to protect or promote their own health. So in the past, health literacy definition used to be just focused on the individual, the individual with the health concern, the patient, the client, and you'll hear me use those terms intermittently. But we know from the research that it isn't just, and actually a small amount of it is due to what the patients bring. A lot of it is due to the way we deliver health care, and so there are things that we can do to make it better for our patients. So health literacy and self-management. Our program, the Southwest Self-Management Program, is a program that supports people living in the community with chronic disease, any chronic disease. And so we hear the term patient-centered care, we hear the word self-management a lot in healthcare lately. And in order for patients or families to actively be able to take part in their health situation or care, they need to be able to access information, so they need to be able to know where to get reputable information. They need to be able to understand the information that they get. They need to be able to evaluate it. So if they're given options about treatment or medications, whatever it may be, they need to be able to understand both options, or whatever, maybe there's 3 options, so that they can make an informed decision. And in order to make an informed decision, we need to be able to understand information, or it isn't informed. And the same goes with consent for treatment as well. They need to be able to communicate with us and let us know that if they don't understand something, to please speak up, and we need to make it easier for them to do that. We also need to be able, or they need to be able to apply the information. So maybe we've shared something that a treatment or an exercise, something that they need to be able to go home and do. So they need to be able to understand the information well enough to be able to apply it when they go home and be successful. So at this point, we're going to launch our first poll, so I'll depend on Janic for that.
Sure thing. Here we go. So the first question is, what is the percentage of people in Canada that have low health literacy? So you get to choose one of the answers. Do you think it's 15%, 30%, 45%, or 60%? I'll give everybody a moment to answer that. Okay. And 55% of you feel that it might be about 45%, and 45% of you think it's 60%. So I'll hand it back over to you, Sally.
Okay, thank you. So the actual incidence of low health literacy in Canada for adults over the age of 16 is 60%. So those of you that said 60% were correct. There was a report done, and you'll see it referenced there on the PowerPoint slide, done in 2008. And so this was across Canada. And what they found was 60% of adults have low health literacy. And when you delve down into more specific populations, 88% of seniors, so people over the age of 66 plus in this report, had low health literacy. Meaning that it doesn't mean that they couldn't read or write. In some cases, they may have struggled with that, but it was more around them being able to take health information and being able to apply it and better their health. So that is a strong incidence, and if any of you are interested as far as this report, you can Google it, and it's actually an interactive report, and it even breaks it down by province, and then within that province, different counties. So, for instance, in our area, we could, look at London, Ontario if we wanted to, and even within London, Ontario, where were the pockets of low health literacy depending on neighborhoods and that. So I do encourage you to take a look at that report. The most vulnerable groups in relation to low health literacy are the older adults, so people over the age of 65, the low-income unemployed populations, immigrant populations, people with limited proficiency in English or French, so depending on where they live in our country. So for instance, I do not speak French, so if I was to move to Quebec, let's say, and try and access health or health information, I would struggle with understanding it. A low education level, although I will stress to you that having a low education level is not the only, is not a big factor. It can be, but there are many people that have a university degree, college degree, have finished high school, and still struggle with understanding health information. And just that I pointed out at the bottom of the slide is low health literacy disproportionately affects more people with chronic disease than any other disease state. Meaning that, for instance, if someone has an acute disease, let's say someone goes in for a gallbladder, they're having gallbladder issues, and the family physician or the surgeons decide to remove the gallbladder. Hopefully if everything goes well, they have the surgery, they're in and out, they recuperate, and they don't have to worry about it the rest of their lives. Someone with a chronic condition, or maybe has gone through cancer treatment and now has, side effects of some of the treatment, they have to live with those side effects or that condition for the rest of their lives. So there's a lot of new learning. There may be a new diet, and maybe a new treatment. And as much as there's great advances in healthcare, with those advances come new learning for our patients. And so they're constantly bombarded with information, and we need to make it easier for them to understand that information. So these 4 skills are very specific to literacy, not so much just to health, but literacy in general. And these are the 4 skills that help us in understanding health information. So PROS skills, or PROS literacy skills, are those skills that we need to read information. So if we have a handout that we give to a patient or a loved one, are they able to read it and understand it? Document literacy is around being able to manage a chart or information in a chart form. So for instance, maybe the back of a children's Tylenol label, it often is in a chart form or in the paperwork that comes with the medication, and it'll tell you by the child's weight, how many milligrams of the medication to give, that sort of thing. So they have to maneuver that chart. It could be an employment form. Sometimes employment forms are set up in sort of a chart manner, or maybe it's a bus schedule. So all those things take into account document literacy. Numeracy is around doing basic mathematical, using basic mathematical skills. So again, going back to a Tylenol label, a parent may have to work out how much Tylenol to give that child in a 24-hour period, and what not to go over, that sort of thing. You know, it could be another medication that requires math skills. And problem solving are those skills that are a little bit more difficult in everyday life. Those are those critical thinking skills where, you know, there isn't always the same answer at the end. And so sometimes I would use the example from my past in working with people with diabetes, in that many of them were on insulin, and you know, we'd counsel them on, you know, if your sugars are between this and this, take this much insulin. If they're between this and this, take that much insulin. So it was always changing depending on their need. And so those are a little bit more difficult skills to manage. And that's why self-management is so important. And one of the things that we teach in the workshops that we run for patients is not so much the clinical aspects of the disease. Those are important as well, but we're not there to teach them that. They, you know, they can get those from many other places. But it's more around the problem solving and setting action plans and how to make decisions based on the information that they have. So some outcomes related to low health literacy is that there's a reduced health-related knowledge. So many people don't quite understand their disease state. They have poor self-management skills, meaning that, you know, they may go home and not understand how to take that medication or how to do that exercise or what they should stay away from or do more of. People with low health literacy tend to use preventative care services less, meaning that, for instance, for example, people may not go in for their flu shots. Women may not bring in, or women or parents may not bring in, you know, their child or their baby for immunization injections on a regular basis, or when they should. Women may not go in for their mammograms when maybe they should at a certain age, or, you know, or someone with a family history of colon cancer, you know, they're not going in for their colonoscopies. It's not that they don't want to. It's more that they don't understand the importance of it and how it relates to their lives. Medication errors is a big one, and in healthcare we tend to call a lot of the interactions we have with patients and family members, you know, that we tend to get frustrated and we say they're non-compliant or they're non-adherent, and I really hate those words, because really what are they non-compliant with? Something that we're directing them to do, and half the time, or most of the time, they don't. It isn't because they don't want to, it's they're not understanding the information, how we've shared it with them. And so in Canada, as of last June, the federal government actually started a plain language drug labeling initiative for medication companies or pharmaceutical companies, in that they have to meet certain standards. I believe it's by the year 2020 in regards to their labeling and packaging. Because what they found in a large study was that in Canada, 1 out of 9 visits to the emergency room departments are due to adverse effects around not taking their medications properly, and they found that 56% of those, or sorry, 68% of those could have been prevented, and it was more around people not knowing how to take their medications, not so much that they were coming in with an allergic reaction or that sort of thing. People with low health literacy tend to use emergency services more. Again, not understanding the healthcare system, how to navigate all the different venues. You know, they could be showing up into emergency room services for a sore throat when they could have been going to their family doctor or nurse practitioner, or maybe an urgent care center, depending on what was in their community. There's a higher mortality rate in seniors and higher healthcare costs. The last information that I can find in Canada was from 2007, I believe, around healthcare costs, and a person with low health literacy costs our healthcare system $7,000 more a year than a person with a higher health literacy level. So these are also, you know, many outcomes, and these are very similar outcomes in the U.S. and even in Europe as far as health literacy concerns, or low health literacy concerns. So health literacy impacts many things. It impacts a person's access to care. It impacts their safety, the quality of care that they receive, their experience, and in the end, their health outcomes. And these are the two main factors. There are the personal factors, what the client or the patient or the family brings with them, and also the system factors. And this is where it's starting to change, where we need to be more aware of, we as a system, what we can do to make things better for our clients. So personal factors, life happens, and I'm sure with those of you that are working with clients with brain tumors, or those of you on the webinar that are family members or friends, you know, you will all see, and how those people experience different things. There may be changes in, visual problems, hearing loss, having difficulty finding words, maybe concentrating, memory problems, fatigue. All those things can affect how well people take in health information, or any information for that matter. So if someone's struggling with physical or emotional health, pain, fatigue, lack of sleep, I think any of us can relate to that. If I've been up all night with, a child and then had to go to work the next morning, I'm not functioning at my best. So those people that are struggling with something like a brain tumor, the treatment they're going through, it really affects how well they can take in health information and actually use it. A person's knowledge about their disease and cultural beliefs. This is a big one, and we really need to be aware of a person's cultural beliefs, because that can fracture a relationship if we come up against some value that they think a certain treatment is more valuable than Western medicine. We need to be able to work with them, and then in the end, it's the client's choice. Also being aware of, even in print material, for example, I had a patient once that said to me, she was from a different country, and she said, Sally, I know here now that I've lived here for a few years, I know that red in Canada means stop or withdraw or do something, that you stop taking a medication or you stop at a stop sign. But she said, in my country, red actually means happiness or prosperity. So a new immigrant that would see maybe a red dot next to don't take this medication, they would not understand that as meaning, to stop something. Also be, aware of a person's experience with their condition in the healthcare system. Just because someone may have had a chronic condition or any kind of a health condition for a long time, we can't assume that they knew from the get-go 15 years ago what that would do to their life, what kind of things they needed to do in order to better their health. I've seen it many times in the past myself where patients were referred to us in a diabetic clinic, and I'm just assuming, because the history says they've had diabetes for 7 years, that they should know how to test their blood sugar properly, or they should be eating the right meals. And that was many times not the case, because people just didn't understand the health information from the get-go and were too afraid to say so in the beginning, and so they did their best in looking after themselves. A person's motivation and their self-efficacy or their self-confidence in themselves, this can be a big barrier and factor in how well people can use health information. If they're not feeling confident, if they're depressed, all those things can affect how well they can focus and actually better their health. So as system factors, we as providers of healthcare, our communication skills sometimes aren't the greatest. We tend to speak way too quickly in a language that people say they can't understand. And we give way too much information all at once. As far as patient education materials, most of it is still in print or on the web now. But our patients often say that it's written in a language that they can't understand. And it's too much text. The places of where we share information with, so the nature of the environment. And what I mean by that is where are we sharing the information with these clients? Is it in a busy 4-bed ward where there's no privacy, there's a lot of overhead pages, those sort of things all going on at once? Those are all distractions, and especially someone who may have been going through a brain tumor or treatment when already having difficulty with fatigue or difficulty concentrating, all those things can make it even worse. So just being very aware of the environment. When I used to work in a hospital, sometimes taking a client out of a 4-bed ward and taking them out in the hallway was a quieter place to do a bit of health education if I couldn't find a private spot than being in that 4-bed ward. I often said to nurses, pulling the curtains around doesn't make it any more private. People can still hear on the other side. And people that are struggling with low health literacy will feel ashamed to say that they don't understand. And so if they have 3 or 4 other people in the room listening, you may ask them if they were understanding something, and they may nod their head yes or say yes, and yet they weren't, or not completely. The other thing to be aware of as far as environment and places is the signage that we use. I always give the example of a client I had that was referred to we were in a small community hospital, and he was referred to a larger urban hospital to see a kidney specialist. And he told me he walked and walked and walked with his wife and could not find where he was going, and came home frustrated The next morning, the doctor's office nurse called and basically was quite upset with him, asking him why didn't he show up for this appointment. They had booked him, so far in advance and had waited so long. And he said, I tried to find it, but I couldn't find anything that said kidney or kidney care or kidney problems. The word on the sign of the clinic he had to go in said nephrology. Now, nephrology is a word that we in healthcare may know, but our patients don't necessarily know. And if we don't even educate them on what the word means, or we don't make the signage easier and just says kidney care center or something like that, we're making it more difficult for our clients. So just keep those things in mind as, it's not just written materials, it's what we say, it's how we as an organization communicate with our clients. So as a system, we expect and we rely on our patients and their families to be informed. We expect them to be activated, that the minute we give them information, they're going to run with it and they're going to be able to apply it. I don't know about all of you that are on the line, but I know that didn't always happen when I shared health information. We expected that to happen, and then in the end they came back to us not understanding, and we'd get frustrated with them when in the end it was really our issue, not theirs. We weren't explaining it in a way or giving it in a format that they could understand. We expect that everybody is computer literate, and although this is improving, not everyone has a computer, and even people that have computers aren't computer literate. There's a difference between being computer literate and being computer comfortable. Even in our program, which most of the people that we serve are, I would say, are over 50. We have a newsletter we send out on a quarterly basis, and we still send it out, most of them by mail. There's over 800 people that we mail out, because I think only 15% of the total amount actually have a computer or use computer. Many people would tell us that they have a computer and they use it for playing games or for Skyping with children or grandchildren, but they don't actually use it for email or those sort of things. So, we do hear the stories that people come in with lots of Google documents, but there are people out there too that struggle, or if they do go on Google, are they going on reputable sites? And so that's some of the information that we provide in some of our workshops too, is reputable sites and where to go on to. Self-managing, we expect them to be self-managing, and we expect them to be partners in care. And this is always, again, the big word, patient-centered care, client-centered care. But how can we expect them to be partners in care if we're not on a level playing field? If we're sharing information that creates a bit of hierarchy, or a lot of hierarchy for that matter, they can't be partners in care because they can't share their thoughts and feelings if, one, they don't feel empowered, and two, they don't understand the health information to ask questions. So this slide here is actually an American slide, but it's very relatable to here in Canada as well. So it's actually based on actually reading and writing. So the average literacy skills of the working adult is a grade 7 or 8 level, and it's lower in the most vulnerable populations. Now, it doesn't mean that people didn't finish high school or university, but this is where the majority of the people are reading at, is a grade 7 or 8 level. Most health information that we develop on pamphlet, brochures, websites, are at a reading level of grade 10 or higher. And research or informed consent, consent forms for treatment, for surgery, are often written at a college level. And again, our patients tell us that we verbally communicate way too quickly in what they call a foreign language. So there is an imbalance, a lot of factors affecting the person, and there's a lot of system demands that hopefully we can change. So what can we do to foster better conditions for self-management? Well, just be aware of some flags. So if you have clients coming in that maybe they need to complete certain forms, registration forms or other health forms, if they're not being completed completely, or if they're incorrect, those may be indications that they are struggling with the information. Sometimes when people come in with their relative or a family member, and we do encourage people to do that, if you've handed them a brochure and explain things to them in a proper way, and yet they're still handing it to the person next to them, it may be an indication that maybe they're struggling again with reading or writing. Or maybe they say something like, I will take this home, or I forgot my glasses, which truthfully so, some people do forget their glasses. But if it's a constant excuse, then it may be that they are ashamed to say that they don't understand the information. Sometimes we also see is frequently missed appointments. or errors in medication or self-care instructions. And so when they do come back to us, we're frustrated because, again, we're calling them, non-adherent, non-compliant, when really it's not that they want to be, it's they didn't understand the appointment card and what it meant to go to the second level, turn right, those sort of things, or that they had to register first downstairs and then come upstairs, or we make it difficult for them. Or maybe it's the medications, take it 3 times a day. What does that mean? Or different self-care instructions. So just be aware of those things. One thing I noticed in my clinical practice is sometimes patients taking a form that maybe had demographic information like, their address, date of birth, that sort of thing. And I would see them pull out a driver's license or something like that, and they would be copying the information from that driver's license onto that page. So it wasn't that they didn't completely understand it, but they were struggling with some information. Now, unless that person had just moved in the last few weeks and maybe the address is new, probably a guarantee that they're struggling with the information that's on that form. And it's amazing what some patients will go through and to cover up things as well. We had a client once that she would always want to book her appointments at the same time on the same day. For instance, I can't remember off the top of my head, but I think it was like a Tuesday at 2 o'clock. And that's when she would book every few weeks. And one day, our secretary had to call her to change the appointment because one of us was sick. And so she changed it, and it was a different day, a different time, and the lady didn't show up. We ended up calling her, and it was almost 2 years later, and she actually explained that she couldn't tell time, and she didn't understand. And so the way she was booking her appointments was she knew that every Tuesday at a certain time there was a show on TV, and when that show was done, she knew she had half an hour to drive to her clinic to get there for the appointment. And that was her whole routine. And so she was very good at covering up that she didn't understand the information, or didn't understand in general how to read or write or even tell time. So again, health literacy isn't just about reading and writing, and I stress to you about that. It's more than that, but that does come with it for some people. So the alternative to testing everyone for low health literacy, which the experts do not suggest we do because we make judgment calls, is to use universal precautions. And universal precautions is a way in healthcare that we have learned over the last quite a few years around treating everyone the same. And it initiated with bloodborne precautions, meaning that if somebody came to the emergency room after maybe there was a major disaster, we would treat the person, any person coming through there, because there might be blood involved in that. We would wear gloves, we would wear protection for all those clients. And we wouldn't base it on whether that person was rich, poor, homeless, whatever it may be. We would treat everyone the same. And that is the same in health literacy. There is a universal precautions toolkit that the U.S. developed, and you can Google that. It's a great toolkit. It has a lot of great tools and things that you can try as a healthcare provider, as a family member, as an organization. And the whole premise of it is that we need to expect that in every encounter that we have with individuals is that there is a risk for miscommunication. And we need to create a shame-free environment so that we treat everyone equally. We can anticipate some communication barriers. We communicate clearly, whether it's verbally, in print, on the web, with everyone. That we confirm understanding with everyone. And this is something that we don't do well many times, and I'll go through that in a little bit. And we proactively work to minimize any barriers that we know may be there. And I also want you to think about this universal precautions in terms of not only working with your patients or your family members or loved ones, but anyone in your daily life. When we actually ran a health literacy workshop here in our organization, we had people who were direct frontline providers of care to patients. We had our business department, we had our IT department, and they all went through the same workshop. And it was quite interesting how we make assumptions. Even though we all work in the same environment, we make assumptions that we all understand each other's language, and we truthfully didn't. There were acronyms, there were things that we would say and do that even though we all work within the same 4 walls, we made the assumption that everyone understood what we were talking about, and we do the same with clients. So think about health literacy not only with your clients or family members, but also even with your team members and any other colleagues as well. So as far as creating a shame-free environment, making sure that the setting Do your best to make it as private as possible, as calm, as quiet. If you could take the patient, a family member, into a different environment, that would be great. Less distractions, less noise. It makes it easier for people to understand health information. Making sure your instructions are clear and concise, not giving too much information, just giving people enough information on what they need to know. Encourage supports, and we always encourage people to bring a loved one or a family or a friend with them. You know, two heads are better than one oftentimes, and especially people that are going through something as critical as, you know, a treatment or going through a new diagnosis. It's always important to have that support there. We also want people or healthcare providers or family members to encourage those patients, those clients, those loved ones to ask questions. And sometimes we don't do a good job of that. And, you know, we end something, we explain something, and we say, did you understand? And, you know, it's a close-ended question, and people will just say yes or no, and oftentimes they'll say yes when they truly didn't. Give time, if we do ask questions of them ourselves, give them time to respond. And again, in healthcare, we don't do a good job of this. We're very good at you know, going through our list of questions on our assessment form and not giving people time to respond, especially people, you know, in your circumstance of the population you deal with who may have time where they have difficulty finding words or concentrating. They're going to need that little bit of extra time to respond to a question. So please give them the time. You know, I think sometimes we're more uncomfortable as healthcare providers with the silence than they are. And so that's why we move on to the next question. Again, privacy is important, as I spoke about, and in body language, be very aware of your body language. If you are, you know, sharing information with someone in person, be very aware that what you say, what comes out of your mouth, must match your body language as well. So what I mean by that is sometimes we're all well-intentioned and we say the right words, but the tone is off. Maybe we're in a rush and we're saying it with, you know, a very rushed tone, or our body language, you know, we may have our arms crossed or standing at the door. That body language isn't really matching what our, you know, our lovely words are saying, and so people feel like, well, she really doesn't want to know about how my day went, or because she's standing at the door, or she's talking really fast, or her tone of voice is off. So just be very aware of all those social cues that, you know, your body must match what you say. So this slide, I throw this up here, and I often do this in person. I won't get the feedback now that I'm on a webinar, but this slide is just to show you that years ago, for those of you that maybe remember, the beer store used to be called Brewers Retail, and that was very strategic back then, but it really didn't talk about what the product was. And so now they have changed it to the beer store. You know exactly what you're going to get when you go to the beer store. So that's what clear language or plain language is all about. Not about beer, but about the whole marketing, the whole sharing of information that in a clear, concise way, so people know exactly what you need them to do or what they need to do when they go home, or, you know, in any environment. So these are some clear language myths that, you know, the first one is that we'll dumb everything down if we speak plainly. And truthfully, we won't dumb anything down. Again, the way we come across as if we're dumbing something down is our tone of voice. And so if that is off, then yes, people will feel like, you know, they'll feel dumb or feel like we're thinking they're dumb. Plain language will insult adults, and truthfully it won't. I think all of us as adults want information in any environment, whether it's healthcare, whether it's at the bank, whether it's at the mechanic, in a language that we can understand. Plain language creates a legal risk, and this is another myth. Plain language does not create a legal risk. If anything, it protects us and it protects the client. The last thing you want the client to do is to sign off on some treatment or make a decision about treatment when they truthfully don't understand, and then they have the treatment done or the surgery done and they wonder what the heck just happened, and that's happened many times. Plain language is just common sense. And this is another myth, and although you would think plain language or clear language would be just common sense, it isn't, especially for us as healthcare providers who we've all gone through our different trainings, whether you're a nurse, dietitian, physician, physiotherapist, whatever it may be. We've all learned a certain medical language, and even within our own colleges we've learned that. And so it's very difficult to communicate with clients, and those words just come out automatically, and we don't even necessarily know that we're using medical jargon. And so plain language actually takes a lot of effort to really think about what we're saying, think about what we're writing down, and sharing with clients. So it's important to use familiar words with people, with anyone. It's about simplifying words. It's about avoiding the jargon, avoiding acronyms, and this is a real big one, is avoiding acronyms. Now, if there's an acronym that you do need them to understand, that is fine, but you need to explain it first and then give them the acronym. We're not saying anyone is not able to learn something new. It just means that depending on the state that they're in, it may be more difficult to take in health information. And so we need to explain it first before we give them the acronym, not just give them the acronym and make the assumption that everybody knows what that means. It's important to give real-world examples, too, if you're comparing things. For instance, measurement is something that is very abstract for people. So telling them that their wound is 4 centimeters by 5 centimeters and 2 centimeters deep, in my home care days, that was very difficult for people to understand. So sometimes we would, compare it to something else so that it made sense in their world. So for example, in diabetes care, we would often say, the meat that you have on your plate, whether it's chicken, steak, that sort of thing, should be the size of the palm of your hand or the size of a deck of cards. And so it was something that was more relatable. So please be aware of that. We often talk about using living room language or everyday language or kitchen language. I tell people, go back to your first language. And what I mean by that is before you got into healthcare, how did you speak? Before you used all those technical medical terms, how did you speak? This slide is around watching your words and numbers. Words can have multiple meanings, especially in healthcare. So diet, for instance, we could mean as healthcare providers asking that patient what their diet is, we're meaning, what are they eating in a day? What are they eating for lunch? The patient may see it as, my gosh, should I have been on the Atkins diet or something else? So diet can be a term that can be very confusing. Stool means one thing in healthcare. It means something else in the general public for most people, and I'll leave it at that. Dressing. Dressing in healthcare often means a bandage over a wound, or it could be getting dressed. In layman's terms, someone who's not working in healthcare, dressing likely means getting dressed, or it might be salad dressing or turkey dressing, so we need to be very aware of that. Gait. Gait is spelled differently, but it still sounds the same. So gait, G-A-I-T, means a person's ability to walk and balance, those sort of things, whereas gait in most people's lives means a gate that you open to a fence or whatever it may be, right? So just being aware that there could be double meanings for those sort of things. Stay away, again, from acronyms as much as you can, but if they are acronyms that you do want them to learn, just explain what they are first. So that, in this slide, for instance, HDL, we would always explain to patients that it's your good cholesterol. You want this number to be high, and we'd explain where we'd want the target. And we'd say to them, so if the doctor gives you something or if you read something, HDL is the good cholesterol, LDL is the bad cholesterol. So again, being aware of that. Also being aware in regards to culture that idioms don't always work. And so, for example, are you feeling blue? We should be asking, are they feeling sad? Are they feeling weepy? Are they crying a lot? Because are you feeling blue in Western society means that. In other societies, it does not. And people can take it actually very literally. And actually asking that you're asking them, are they feeling like they're blue in color? It's also important to explain the difference, especially around risks in relation to is and may. Because especially when people are going through something traumatic or a new diagnosis, there is a difference between something is going to do this or something may do this. And so making them aware that there is a difference, because often, people are so stressed and they're taking in the information, and many times they hear the may as something that will happen or that it's an actual is. So taking the time to explain those things. If you're writing something or developing a brochure, it's important to use one idea per sentence. Words, and it's very difficult to do this, to use 2-syllable words or less. This is plain language, which is very difficult to do in healthcare. But do your best. The average sentence length should be no more than 15 to 20 words, 20 at the max. And we probably all learned back in elementary school or in English class in high school, you don't want an ongoing sentence. So it needs to be cut off or it's too long and people lose the interest or even understanding. Simple punctuation, making sure the tone of voice of a sentence is, is positive. So avoid using words like you should do this, you must do this. There are other ways to invite behavior than using that type of tone. If you do have a glossary or terms that you want clients to understand, don't have a glossary at the back of a pamphlet or at the back of a booklet. Explain the actual word within the document, so within the paragraph, so that people aren't losing the focus. So if they're reading a document and they have to go to the back of the book to read what does this word mean and then flip back to it, they've lost the reading comprehension. So just being very aware of that. If you're giving, as far as instructions, this is just an example of post-op instructions at a hospital. And so originally it was notify your physician if you develop the following complications: incisional pain, inflammation, fever. What does that mean? What does incisional pain look? What am I supposed to look for when I go home? What does inflammation look like? What does a fever feel like? And so they changed it to make it simpler so that it's actionable, so people know what to do. They've changed a few words. You will see that, call your doctor. Doctor is a more simple or plain language term than physician if you have any of these problems instead of complications. So the pain in your incision, and incision you may actually have to explain what that is. I use simple terms even as where they opened you or cut you. Does not get better with pain medication or medicine. So that's explaining what incisional pain is. Your incision is red and swollen, so that's explaining what they should be looking for as far as inflammation or if there's anything oozing out of it. And sometimes, unfortunately, you're using quite graphic language. And as far as a fever, you have a fever above 38 degrees Celsius, or if they're using Fahrenheit, 100 degrees Fahrenheit. And again, you may have to show them how to use a thermometer, depending on if it's something new for them. As far as clear design, it is not an add-on when you're doing print material. Designing print or web-based materials, you need to make sure that the material is inviting and easy to read, but that it's purposeful as well. And you'll see the picture that I just picked out of Google and posted there on this slide. There's a balcony, but really there's no way to get out there. It serves no purpose. And that's the same as sometimes when you pick up a pamphlet. It has a person's face on it, has nothing to do with the information that's in it, or it's, the pamphlet is for somebody that's older and it's got a young person on it, or that sort of thing. So clear design is purposeful. It's not just to make something pretty. So as far as design tips, on any patient handout or material that you may provide to people, there should be ample white space. You should have half-inch margins all the way around of white space around your document. And the experts actually say 30 to 50% of that document should be white space, meaning that white space or visuals. So meaning that that's not leaving you a lot of room for text. And so you need to make sure that the text is very simple, very concise, and you're getting to the point and you're answering questions that people actually want to know, information about. So, 30 to 50% of it should be white or pictures, relatable pictures, or diagrams. Then that's not leaving you a lot of room for text. As far as the text, it should be easy to read, 12 to 14 point font. As far as color, the best contrast would be, especially for people maybe who have gone through, a brain tumor and treatment and that sort of thing, and that have maybe visual issues, and even older adults for that matter. Color is very important. So I would recommend that you use the most contrast, which would be black on a white sheet of paper or a dark print on a black sheet of paper, or on a white sheet of paper. So something with a light background and a dark print. Some of the studies actually show that older adults have a difficult time seeing blue or green, so staying away from those color of texts as well. Bullet points are very useful in the document. Instead of it looking like an overwhelming page of just text, bullet points are great to get to the point with things, but you can overdo it as well. So the experts actually say no more than 7 bullet points together. And if there's more than that, then you need to shrink down the information and really look at what's the most useful thing. If you want information to stand out, you need to, you can bold it, you can put a text box around it, but stay away from italics or making it all caps. And helpful pictures, again, going back to the design, that the pictures should relate to the content of the brochure or the handout. Maybe it's an actionable and it's showing them how to do a certain exercise, or at least that it's relatable. It's even culturally. If you work with a specific population, let's say the Aboriginal, you would want people in the pictures to be Aboriginal descent so that it makes it more appealing to them. So how do you know if your material is clear as far as print? Well, you can skim the material, you can read it out loud, but those sort of things can make it difficult. You can ask a colleague. The best way is to get audience feedback. So if you develop something, I would encourage you to take 3 or 4 of your next patients, and before your document's still in draft, and ask them for feedback. They're the ones that have to use it, and if they're not understanding the information, then you might as well scrap it. So it's important to get their feedback. You can use a variety of resources. You can use print, verbal, video, audio, web-based. There's many things out there, and people learn in different ways, and that learning changes. One of the things that studies have also shown is that if you've given someone a brochure, it's important to put their name at the top and mark it up. If there's important information you really want them to understand, mark that up, because sometimes, for instance, you're working with documents that you didn't develop, but an association did. And even though there's good material in there, there may be some things that are nice to know but not need to know. And so you want to highlight the most important things in it. But most importantly, we need to check for understanding. And so it's our responsibility to communicate clearly. And this quote was from the U.S. Surgeon General. As clinicians, what we say doesn't matter unless our patients are able to understand the information we give them well enough to use it to make good healthcare decisions. Otherwise, we didn't reach them, and that is the same as if we didn't treat them. So this cartoon that I often use is very real. We often give instructions, for instance, with this medication, take with meals. No problem, I eat all the time. And generally, when we say take with meals, we mean 3 times a day, but there are people that eat 5, 6, 7 times a day. So if they were taking the medication all those times, they can easily overdose. So again, it's just being aware of how we share information and what do we actually mean, and making sure that it's clear and concise for people. So at this point, we're going to launch the second poll. I'll have Janic help here.
Here we go. So what is the percentage of people who understand the answers to their questions upon discharge from hospital? Do you think it's 14% of people, 21%, 33%, or 45%? I'll give everybody a moment to answer that. Okay, looks like everybody's answered, and we've got a mix of answers. So 30% of you think that it's 14%, 30% of you think it's 21%, and 40% of you think it's 33%.
Okay. So the correct answer is 33%. There was a study done by Health Quality Ontario 2 summers ago, and what they found is 1 out of 3 people being discharged from hospital did not understand they did ask questions, which was great, on discharge, but they still didn't understand the answers to their questions, and they went home not understanding what to do when they went home. So it is a high percentage. And so the teach-back method may be something that you all already using, you just didn't know there was a name for it, but it is one of the top safety practices in the world. It's not a test of the patient, but it's a test of how well we've explained an information, whether it's verbally or written or both. So it's quick, easy steps. It's around thinking about information before that patient even comes to see you. And what is the most important information? What can we triage? What are we going to give them that's the most important that they need to know today? Maybe there's a whole bunch of information that they need to understand over the continuum, but today, in this stressful time, what is it that we need to get across to them and they need to understand? When we get that piece of information that we're going to share, then we're going to share it to them, explain it to them, in plain language, slowly, and pauses. And step 3 is around after you've shared a piece of information, and let's say you have a document that has, 8 points on it. You're going to share maybe the first 2 points, and then you're going to stop and you're going to gently say, I want to be sure I did a good job explaining that. Can you tell me or show me if it's something they just say back, or maybe it's something that they need to show you back, like how to test their blood sugar, whatever it may be. So I want to be sure I did a good job explaining that. Can you show me or tell me what you understood? And you get them to show you back or tell you back. This is the point where you can confirm whether they got it or not. And if they didn't, that's okay. You don't call them out on it and just say, you know, this can be confusing for many people. Let's go over this again. You're going to have to say it a different way. If it's something you're going to show them, you're going to have to make sure that you show them, maybe it's the same way, but that you go through the steps a little bit slower or take the time to do that. And again, it's about, so it's about listening to them, giving them time to respond, and you clarify things, and then if they got it the second time, you move on. If they didn't, you need to say it again. It may sound like you take a lot of time to do this, but truthfully you're saving yourself time, because if people aren't understanding the information you're sharing and they're going home and coming back to see you in a month, 2 months, 3 months, and they still haven't followed through on the treatment or whatever it is that you're sharing with them, you're both going to be frustrated and you're starting from square one again. So Teach Back is about giving people chunks of information in an understandable way, not all at once, and stopping and putting the onus on yourself. So use whatever is natural to you. It may be, you know, I wanted to make sure I did a good job explaining things, or sometimes I'm not very clear when I explain things. Can you show me or tell me in your own words? Because using that little bit of STEM at the beginning puts the onus on us, not on the patient, and then they feel like they're not being tested. Because if we didn't use that STEM at the beginning, or that starting piece, and just said, now show me or tell me what you're going to do, that gets their backs up. So just being very aware of that. And we need to stop, you know, using the term, do you understand, at the end to check if somebody's understood something. You know, it's again, it's using Teach Back and saying, you know, using those gentle stems or whatever way that sounds natural to you, but putting the onus on yourself, that it's your fault if they didn't get something right. We want you to invite questions from your clients. So again, instead of at the end saying, do you have any questions, which is a yes or no answer, you know, the correct way or the more effective way is, what questions do you have for me? What parts of this were difficult to understand? That leaves it more open. It seems more inviting to people that, oh, if she's asking that, there must have been other people, you know, that had difficulty. Or you can normalize it, you know, and say, you know, when I've shared this information in the past, people have lots of questions because this is all new. What questions do you have for me? And again, this chart just shows you the types of questions. The less effective are those ambiguous ones or those closed-ended. And I'm not saying that closed-ended questions aren't important. In certain assessments, you know, there are closed-ended questions that we need to ask. But when you're trying to confirm that someone understood the information that you shared, you need to use those open-ended questions that gives people time to tell their story and use Teach Back, starting with that STEM, so that it puts the responsibility on us, not on the patient. So I just want to share, lastly, a slide with you that a colleague shared with me, and this is the Chinese sign or word for listen. It's very interesting because to listen, it means just more than your ears. It means your eyes, giving undivided attention, using your heart, and using your ears. And all these things go into listening, to really listening to somebody and putting your agenda aside. And that's often what we need to do in order to check for understanding. So in summary, anyone can have difficulty understanding health information. Yes, there are those most vulnerable populations, but I will tell you that any one of us on this webinar today could struggle with health information at any point if we're put in a stressful situation. It affects our health, safety, quality of care, and experience. And so we need to promote self-management and a better way of delivering care by creating a shame-free environment, by using clear language and design, using different resources to reinforce learning, and to using the Teach Back method to confirm understanding. And I'll leave you with this quote: the greatest problem with communication is the illusion that it occurred. And this often happens. You know, we think we've communicated really well, and really it was just an illusion. And people on the other end didn't really understand. So I think that's it. So thank you very much for everyone for listening, and I'll take any questions, Janic, if there is any.
Great. Thank you so much, Sally. What a great presentation and such great information and great reminders as well for all of us who are communicating with those who have been affected by a brain tumor and maybe even other clients that we're all working with. There's no questions that have come through, but I'll give everybody just another minute or two to type those questions if you have any for Sally. And while we're waiting another minute or so, I'm going to switch myself as presenter, Sally, so I can just show a couple slides as well. So just give me a second, everybody. So just as we're wrapping up, and just wanted to give everybody some reminders of some other programs that we have happening this spring as well as right through the fall. We have our Information Day conferences happening from June until November. So for those of you in Saskatoon, Vancouver, London, Calgary, and Halifax, we do have events coming up in your areas, and all that information and the details of the speakers are on our website as well to register. We also have, we're actually in the middle of our Spring Sprint program, which is our largest fundraiser program across the country with over 20 cities hosting the Spring Sprint. So if you want to check to see if there's a Spring Sprint in your area, please visit springsprint.ca for a list of participating cities. And you can help us raise money for programs and resources and research here in Canada. And our next webinar is actually going to be a webinar in French on Wednesday, June 18th with Dr. Thierry Muenza from the Jewish General Hospital, and the topic of his presentation is la radiothérapie pour les tumeurs cérébrales. All right, so it doesn't look like we have any questions from anybody. Oh, actually, give me a moment here. Okay, so one question, Sally.
Okay.
I'm a brain tumor patient and find that literacy goes the other way too and have trouble with my specialist listening to personal issues I describe. Would you say that bringing literature for the doctor would help or make him shut down?
I don't think it would shut down the conversation. I think it's sometimes the way we approach it as well. Again, it's around our body language and bringing that information. So I guess difficult to know the context, but I encourage patients to bring information with them, definitely, if it's something they've found. But also being aware of where you're getting that information from. Is it reputable source? Because, you know, many a times as healthcare providers, we hate seeing when, you know, people bring in something that, you know, there was a magical cure for something yesterday and all you have to do is take, you know, one pill and you'll be cured. And so I think that's sometimes where healthcare providers get frustrated. So I think if you bring in literature, information, or maybe it's a health history, whatever it may be. I'm not familiar with the context of the question, but making sure that, you know, you have information to back it up. I think it's very important to start that conversation because you have rights as well. So.
Great, thanks, Sally. And just one more question. It sounds like this is from one of the healthcare professionals. How can we partner? How can we partner up with patients and family members in this process?
In relating to, as far as, you know, it depends. If you're trying to partner with patients and clients on a one-to-one, I would encourage you, again, if it's print material, I would encourage you to ask for their participation in developing the material. If it's an organization, the same thing. There's a lot of information out there on experience-based design, which is about engaging clients and family members in the care that we provide. So whether it's print, whether it's what we say, whether it's processes that we use, it's very important to get their buy-in because that's where we struggle with people not understanding information if we don't make them part of the conversation. So.
Great. Thanks so much, Sally, and thanks to everybody who had those questions. And once again, thank you to everybody who has signed in today for our webinar, and to you, Sally, for taking time out of your schedule to join us today. And we'll just sign off now. And as a reminder, the webinar will be up on our website within a week or two. And so thanks again, everybody.
Thank you. Bye-bye.